So nice to be here. So what I do mostly is take care of patients for a living. So for 3 days a week, I'm an internist at the Fano Creek Clinic. And I still do have an inpatient practice, but just this last week we switched over to Good Sam. So we see our patients at Good Samaritan Hospital. I'm medical director of the PA program, physician assistant program at Pacific. And but what I'm most here today to talk about is what to do at end of life, encountering the patient and facing end of life. It turns out that someone asked me once, what's the mortality rate in Oregon? And I say it's 1 per person. So we're all going to be here. This is all of us. So it's all of us, it's our family, and it's time to open up the conversation about it. I'm so glad that the Right to Life group here is looking at the full life spectrum. And so I'm really happy to be here. And so what we're going to talk about is what happened when my patient had an assisted suicide. We're going to cover a little bit on suffering depression, conserving dignity, some successful strategies, and we're going to end on talking about advanced care planning. But there's a whole session this afternoon, and it looks like it's in the one right after lunch, A Christian's Guide to Filling Out the Advanced Directive. And I'll leave a lot of my comments about that towards the end. We'll just kind of brush over it. It sounds like there's a whole nother session on what to do with advanced directive and POLST. So I'm going to start with my patient. So I'm in my practice and I see a patient who's 76 years old. He comes in, has a lesion on his arm. It turns out to be a melanoma, and it's basically metastatic, and we start him off on chemotherapy and radiation therapy. Halfway through his course, he sees his oncologist and actually gets quite depressed and decides he wants to do assisted suicide. So his oncologist calls me to be the second opinion for his assisted suicide. And I declined to participate in the affair, and I also said, well, but there's other things that we should be thinking about. Someone, who's at this stage, let's make sure they're not depressed, and let's make sure we're doing good care and all the rest. And anyway, she went ahead and decided to assist him anyway, and 2 weeks later, he was dead. So my patient was given assisted suicide, despite my objection and all the rest. And so I had to figure out what happened. I still take care of the widow, and I know what happened. And I decided to find out, well, golly, if this is the person who I refer all my cancer patients to, and what should I think about this? So what should I do? And so I decided to talk to physicians. I was a physician. I was working at St. Vincent here in Portland, and I decided to start to talk to patients. So I talked to the director of palliative care services, and I asked him, well, what do you think about assisted suicide? And he said, well, golly, it's been a good thing for palliative care, because it's got all this interest and all these people now talking about it, and it's been really great for our business of palliative care. And I said, okay, well, golly, that's one way to look at it. So I talked to another person who was basically a person who was an oncologist who I really respected, and he said, well, I don't do it, but I refer to people who do, because it's a choice that they have now in Oregon. And it turns out that this was one of the people who helped fight against assisted suicide. But here we were, 10 years later, and this was going on. And so I asked another patient who was actually on the board of Physicians for Compassionate Care. So this is someone who was on our board who was really opposed to the law. And I asked her about this, and she said, I used to really be against it, but now I got to tell you, I could see it maybe. After a decade, nobody's been struck by lightning here in Oregon, so it must be okay. I also saw another patient, another physician. This was a resident of mine. I used to be an instructor in the residency program at St. Vincent. And so I saw her. We were up on the 7th floor. We were having a conversation about, patients. I was just trying to learn more about what my colleagues felt. And she told me about the case of this patient who was horribly suffering at the end of life, and she just couldn't stand to see it anymore, so she just had to write that prescription to put the patient out of her misery. But it was the misery of the physician who was suffering to watch this patient suffer. And then I talked actually to the doctor who gave my patient assisted suicide. And she said, oh, golly, no, I do this all the time, and this drug, secobarbital, works pretty well, generally. And so I just started talking to these physicians that I knew and I worked with on a day-to-day basis, and I had to start to think about, my patient was dead. How did I feel about it? How did I feel about myself? How did I feel about my colleagues? Was appropriate care given? I delved into the record, and it turns out my own patient had seen the medical oncologist, or the radiation oncologist. He was getting radiation therapy and medical therapy. The radiation oncologist had documented in the chart that this patient was depressed. And then the medical oncologist, instead of treating their depression, actually said, oh, they're depressed and suicidal. Well, here you go. And that's what happened to my patient. And what could I have done differently? I really, I thought about it. What should I have done when hearing about this? What alarm bell should have gone off? I said, we probably shouldn't do this, was my response. Because first of all, it doesn't sound like good medical practice, and also we don't do that here. Because we were at Providence. This was the medical director of the Providence Cancer Program, after all. We don't do that here. Well, it turns out my patient was dead. And what would I do next time? So what I wanted to do is to come up with a program for what I would do. And that's what I'm going to share with you. And again, it captures a lot of stuff about end of life, but it helps to first talk about what is the death with dignity law, the so-called death with dignity law. Here in Oregon and now in Washington, it's legal if a doctor says, and it doesn't have to be true, but if you can get a doctor to say that someone has less than 6 months to live, a patient requests a lethal prescription, they need a second opinion, but it can be done over the phone by someone who doesn't know the patient. A 2-week waiting period, you write the prescription. You basically, the reporting of all this to the state is voluntary, and the record, actually, you can't put down that they died of assisted suicide. What you have to put down in the record is that they died of the cancer, and actually my patient's death certificate, instead of that the oncologist wrote out, filled down that they died of their cancer, when in fact what they died from. Now this is actually the law. This is what got passed. What got passed in Oregon and Washington provides not for patients, but it provides for doctor order, doctor prescribed, and doctor directed suicide. That's assisted suicide. That's the law of the land. What's been happening here in Oregon, this was just published this last month. What do we see for the statistics? Well, we see that the rates are going up. You really can't see I guess on the side to the right of each one of those black lines is a little gray line. It doesn't really project that well. What we have here, again, you can see some of the statistics about who actually is getting involved with assisted suicide. It's mostly older white people. Of course, that's, Oregon. The concerns that they have are mostly about autonomy and enjoyment and dignity. Very few people are being evaluated for psychiatric reasons, and they've had 2 failures, one pretty dramatic, where people, they take the drug and it doesn't work. And this was just in 2010. Why do people choose assisted suicide? On the surface, it might seem like a logical conclusion. People experience a tragic death all the time. Everybody here in this room knows someone or knows someone who's just witnessed a tragedy at end of life with poor care. They're fearful of the suffering that goes along with that and the pain. And they're concerned about not being able to be in control. And there's a fear of this sort of being a burden or the dignity that we have. And also there's depression at late life. And a lot of people here in Oregon, with the Oregon Trail, we want to die with our boots on, go out on our own terms. It's very, very important. And so these are some of the reasons. When we take into account suffering, what is suffering? If you look at suffering, suffering is something that's a subjective experience. And it's always associated with events that threaten something that breaks apart what we consider what we call personhood. So what does it mean to be a person? Well, persons are individuals. They have thoughts, they have desires, they have political views, they have actions, they have secret life that goes on inside. Every one of us is an individual person. And suffering happens when what we think should be whole is being split apart. So in other words, if I think of myself as a healthy person, being able to do something I like to do, and if I can't do it, well, there's a suffering in that. If I'm separated from my family or loved ones, there's suffering with that. If they're separating me from a role that I want to do, there's suffering in that. And so it's always associated with a loss of something, a separation from something, and there's always a component of uncertainty or fear. When we talk about suffering, people report unexpected suffering all the time, especially at the suffering of a loved one. If you have someone who you love or someone's close to you and they're suffering, your suffering is just almost as intense. People can report minor pain, but they report all sorts of suffering with and you might think, well, golly, that's not really that bad, but they're really suffering from this. Why is that? And a lot of it has to do with the uncertainty. So, for example, you'll see a patient who's got a back pain, and she really knows that, everybody in her family's died of pancreatic cancer, okay? And she's sitting there in the emergency room, stricken, because she knows that this back pain, she knows that it's the pancreas, okay? She didn't go to medical school. She didn't realize pancreas is over here. But she's just certain that that's what it is, okay? And she's just, all of a sudden, we tell her, oh, it's a kidney stone. Well, kidney stones are horribly painful. But a kidney stone's a kidney stone. And it's going to pass eventually. And all of a sudden, the suffering, the pain is just as bad. But the suffering is lessened. And everybody in the room, all of a sudden, now they're joking, okay? Where they weren't before. Because they were just convinced that this was the beginning of the end. So there's this fear of the future, the uncertainty that's really really central. And at end of life, when we really don't know what's going on, families don't know what's going on, you have to pay real close attention to this, and we'll get back to that. So, and also, what to do at the end of life. So this is a real brave soul, woman who was gone through 2 rounds of chemo and 3 rounds of chemo, 2 rounds of radiation, and she was quoted in the Seattle Post-Intelligence, and they asked her, well, what about the end of life, and what about assisted suicide? She said, well, how do you teach your children how to cope with life and death? I want to show them that death is part of life. It's not something to be feared. I can't hide from it. You can't deny it. And they said, well, what about assisted suicide? And she said, well, I'm completely at peace. I know I'm doing the right thing. I want to show the grandchildren strength and adversity. Why would you want to cut yourself short? This is a brave, brave soul, a hero of mine. My mom. And what we have is someone who you have to be really careful when you see end of life. Now, does this look like someone who's depressed? Not really. But you see that. What about my patient? And depression is something we really have to be careful and we have to look for. What is depression? If you look it up in the Diagnostic and Statistical Manual that kind of gives the definitions for mental health issues, they say, well, depression is 2 weeks or more of depressed mood with a loss of interest or pleasure, a change in patterns of sleep, feelings of guilt or worthlessness, lack of energy or fatigue, impairment of your concentration, change in your appetite, psychomotor agitation, which you're agitated or retardation, you're kind of slowed down, and recurrence of thoughts of death or suicide. Now, this might just be, oh, golly, that's like Tuesday for me. So, that happens on Tuesday, okay? I'm talking about 2 weeks of pervasive mood. You'd be surprised at how many people here in this room qualify for a diagnosis of depression. Now, why is this important? It's important because it's treatable. Depression's treatable. It's curable with simple things that are now medicines that are $4 a month. I mean, really, really treatable. And so it's worthwhile looking at. But we don't recognize late life depression because, well, golly, old people are depressed, and nursing homes are depressing. Sick people should be depressed. If they're not paying attention, right? Old people have lots of complaints, if you're in my business, you see it. Also, there's all these medical issues and depression. Golly, what about their high blood pressure, their diabetes, and their neuropathy? And not only that, it's, Medicare's not paying for this thing. What are we going to do? And we don't like to give labels, and there are people who don't like to have labels. And also, with older folks, sometimes it's not depression, but it's apathy. Apathy is a cardinal feature of late life depression. And I got to tell you, in my busy practice, I'm seeing a bunch of patients a day, and if it's not bothering them, it's not bothering me. It just moves the visit through. And so actually apathy is almost guaranteed to be unrecognized unless someone comes up and brings it up. And when we look at late life depression, and we look at the difference between adult depression and late life depression, we'll see that some of the features are really, really different. So whereas a young or middle-aged, they're really depressed or anhedonic, which is you lose the sense of pleasure. If you're late life, it's weariness or hopelessness or just angry or anxious could be what it is, and maybe not depressed at all. So we don't recognize the main symptom. Also, there's all sorts of somatic complaints we think about, but when you see late life depression, it can also increase pain, it can cause problems, all sorts of symptoms, but it gets lost if they have multiple medical problems. And also, you can see in maybe middle-aged indecisiveness or lack of concentration, but in older folks, you can actually see decreased concentration, decreased attention, their processing speed go down. We actually call it pseudo-dementia. It's a dementia that when you treat their depression goes away, because it's a type of a dementia. So we lose this. Now, and again, it's important to recognize this, because if we can see it, we can treat it, and it resolves. And my patient, I don't know. He was actually, the radiation oncologist said he was depressed. And would he have, with just a couple of weeks of a medicine, gotten his youth back, or gotten his optimism back? I don't know. I will never know. So what about when someone asks about assisted suicide? What should you do? Well, the first thing is you don't want to avoid the conversation. If we avoid it, it might be seen as a rejection. We can't do that. And it may be a failure to hear the cry for help. And for millennia, when someone was depressed, we interpreted that as a cry for help. And now in Oregon, we help them, in a different way. And so we have to figure out this. We have to get this back. We have to understand what it is. And it may be that there's depression. It may be that they're just curious. Or it may be that there's a person who really wants the, inheritance. And as we all know, we've seen it. We've seen some of it. So what about dignity? So this is a great painting. Love this painting. It's titled Impudence and Dignity. So whose impudence and whose dignity? So when we talk about dignity, what is dignity? Dignity, and if you look up the definition, it's the state or the quality of being respected, of having self-respect, having esteem, of a stateliness, of a bearing that we have worth or self-value. And that's what, when people think about dignity, that's what they think about. And it's important to understand that there are two kinds of dignity. There's attributed dignity, which is what most people think of when they think of dignity. And attributed dignity is the perception of autonomy or individualism or ability to walk around on our own feet and do our own thing. And there are a lot of things that diminish that. Pain is a huge factor that diminishes our dignity. As people get older, late life, bowel or bladder dysfunction, horribly embarrassing and can diminish dignity, this attributed dignity. Dependency issues, being dependent upon others, and physical appearance. And when people talk quality of life, this is what they're talking about. And it's understandable, because that's what most people think of when they think of dignity. There's another kind of dignity, intrinsic dignity. Who recognizes this? Martin Luther King. And where was this? Birmingham, right? In a jail. So the circumstances of this, and this is, I think, when you talk about dignity, I always bring this up because it's my favorite picture. Was it a dignified position for a black man to be in jail in the 60s? No, it wasn't. What happened before this was that he went to the president and said, we need equal rights, and we need them now. The president said, the country's not worth it. And he was actually said, well, then I'm going to march. He's going to march for civil rights. He was told that he would be put in jail. Many people said, listen, you need to fight for equal rights, and we should have an armed rebellion. And he actually said at this point in time, there are things for which I'm prepared to die, but there's nothing for which I'm prepared to kill. And he decided to march in peace. And he got put in jail. But look at his face. I mean, he knows who he is. He knows where he is. He knows why he's there. He knows where he's going. And that is dignity. It has nothing to do with the circumstance he finds himself in. And let's just bring that over to end of life. We have someone who's in a hospital bed. They don't look dignified, but if you take a step back and remember who they are, where they're going, you can get this sense of dignity, this intrinsic dignity that's inherent in every human. And that's when we say this intrinsic dignity is inseparable from who we are and where we're going. And what we need to do is we need to have a stance with everyone in our families of unconditional positive regard. That no matter where you find yourself, no matter what circumstance you find yourself, there's unconditional regard for you as a person, as a human being on the planet. And what we need to do is how do we identify this? How do we capture this? How do we keep this alive throughout the end-of-life process? Well, we need an approach to conserve dignity. We need to do something that will preserve this way of thinking. And it's hard to do. But there is an approach, and I'm going to go over real briefly with you. And what I'm going to do is I'm going to go over a dignity-conserving repertoire. And there's a series of 23 questions. And there's a question, and there's a theme, and there's the underlying thing that we're getting to. And I'm going to go over a couple slides. And this is all available on our website, so you don't feel like you have to take a bunch of notes. You just have to have access to the web, and you can get all this. But so the level of independence. So you talk about independence. You might ask someone, well, how has this illness made you more dependent? And what we're trying to get at are getting patients involved in their own decision making. So I had a patient who was a policeman, and he was in the hospital, and he had a heart attack, pneumonia, and a stroke. Okay, and he was going to die. But we brought him back, but he was really on death's edge and decided to go on hospice. And he comes back to the clinic after surviving this hospitalization, and he actually asked me for assisted suicide. And my first question was, what's going on? And he's just in bed. He's used to being in charge, and he's completely now dependent. And so I talked to his wife, and I said, what we need to do? And I actually made a house visit, and what we did is we got a big hospital bed. We put it right in the front room. And we put a channel changer and a big TV and when he could take his medicines and who he could see. And pretty soon, guess what? He was directing traffic again. And you know what? He lived another 2 years and died happy. He actually got so happy, one day he got up, decided to kick the dog, and fell and broke his hip. So now his wife was truly a saint. I'm convinced of it. But I'll remember this guy, and he really wanted me to kill him. But what he really needed was to be a little, and it wasn't that he needed to be independent, he just needed to have some control. The second question, what about cognitive acuity? You want to make sure people are thinking clearly, and is there any way we can address the drugs? Functional pain, how much you're able to do for yourself. So I have another patient, and this is a gentleman who had horrible pulmonary fibrosis. Maybe you know what this is. It's a scar tissue that takes over the lungs. And slowly, as your lungs fill up with scar tissue, it's harder and harder to breathe. And so he comes in with his wife, and they're in my exam room, and I have a resident with me, and he asks me for assisted suicide. And, it's like, well, what's going on? Tell me what's happening. Well, I can't get around as much anymore. And this guy was used to getting out and doing stuff. He wanted to go to the games with his grandkids and all the rest, and the intervention was real simple. We got him one of those electric scooters that you just see on the commercial. Actually, all you got to do is ask for one, and they'll fill out the paperwork for you, So the next clinic visit, here he is, and from across down the hall, he's got these big eyes, and he's chasing people down the hall. As a matter of fact, at his eulogy, which happened 3 years later, his pastor got up and said the week he died, he was chasing him down the hall with his scooter. He was legendary. And now the scooter is in, his widow. I still take care of his widow. And the scooter's in their garage, and whenever the grandkids come over, they play on the scooter. And it's one of those things. And for this person, it was just about mobility. And he was suicidal. He wanted to end his life. And it really was something simple. Now, there's a whole bunch of these questions, and we have lots of options. So what about, physical distress? How comfortable are you? So I have a patient who's, she's actually, she's 65-year-old, and she's in the hospital, and she's agony because she's got metastatic lung cancer. It's filling up her lungs. She's got metastatic lesions to the bone. She's in pain. She's anxious and short of breath. So we give her some IV morphine. And IV morphine does something pretty amazing. It's actually a bronchodilator. It relaxes the lungs. It allows blood flow through the lungs. The breathing's easier. It's a pain reliever. There's no more pain. It's a little bit of an anxiolytic, so there's less anxiety. She's comfortable. And she actually, because she's not struggling anymore, she really kind of relaxes and lets go, and she expires, pretty soon. Not that day, but, with treating her appropriately, she actually, instead of hanging on for weeks, miserable and struggling, she lets go and has a peaceful death. Now, this is good medical care. And from the outside, it looks like, oh, golly, they gave her some morphine and she died, killed her. And you see this all the time, when in fact, this was good care. And there's a lot of people who are confused about this. And they say, golly, they gave my mom morphine and she died, and I know we killed her. Turns out, well, it might have been. It all depends upon the intention. Sometimes they're suffering so much, you ease their pain and they let go. And there's always someone who's all of a sudden they're thankful because they've just been carrying this burden forever. And they hear this and they go, oh, okay, that's all right. This is good care. And there's a lot of people confused about this. Now, it all comes down to intention and what's going on. So you have to have people with good ethics right at the start there. So a lot of other questions about this. Patient perspectives. For example, what about this illness doesn't affect you, and what are the things in life you're most proud of? How in control? How do you want to be remembered? Favorite story, I share it often, is that I was the hospital doctor at St. Vincent, and I was rounding just for the weekend. So that means I come in on a Saturday morning, I get a list of patients, I got to see them, and I see them on Saturday, Sunday, and then I'm back in the clinic on Monday. And I get this list of 14 patients I'm going to go around and see, and the one who's up on 7th floor, she is, the checkout for her is, there's a lady who has terminal liver failure, and she doesn't qualify for a liver transplant. So the decision was made that night, the next day, that she's just going to go on hospice. And so literally on my checkout, there's really nothing to do. And so I walk into, I'm running through, trying to see all the patients and talk with families, and I come into this room, and it's one of the most bleakest rooms you could ever walk into. So here's a lady, she's in bed, she's in her 30s, and she's yellow, and she's dying, right? And her husband, who's in his 30s, is crying. Her parents, who are in their 60s, are sitting there and crying, and there's her 10-year-old daughter, who's kind of rolled up in the corner, almost in a fetal position, just bewildered. And you just sort of stop, and you're like, okay, what do you do here? Okay? What in my medical profession has trained me to do here? And it was actually at a conference like this, and I said, we don't have that much time left. With liver failure, it's going to be a couple of days, and you're going to go into a coma, and you're not going to be awake and alert, okay? So how do we want your daughter to really remember this? How do we want her to experience these next 2 days? And wouldn't it be nice if, we made a plaster mold of your hand, and then that way, no matter through the rest of her life, she'd have something to hold on to. Wouldn't that be nice? And all of a sudden, it was like, a parting of the clouds, a little bitty glimpse of sunshine. And all of a sudden, they said, yeah, let's do this, and let's go through this. As a matter of fact, there's an intervention we can do here, and it's actually a dignity-conserving repertoire that the nurses could go through. And I actually got this printed out, went to the nurse and said, forget your plan of care today. I want you to go through this. And this is just something I want you to go through with the patient and the family. And it's a simple, 12-point thing here. And just have the patient be there with their family. And tell me most about your life history. What are the parts that you remember? When did you most feel alive? Are there things that you want your family to know? What are you most proud of? What are your accomplishments? What are your hopes and dreams for your loved ones? What have you learned about life you want to pass on? You want to make a permanent record of this, and what would you want to include? And let's just take someone who's really good. I want the best nurse on the floor to do this. And so we started talking about this. And then I left the room and I realized, I need to make one of those molds. How do we do that? Now, I'm really obtuse, and so you all know the answer to this. But I said, oh yeah, plaster. You know who used plaster? All the dentists, right? So I called the oral surgeon on call. And he's like, he didn't have a clue, right? All right, so I'm like, okay. And why did I bother him? And so I said, plastic surgeon, right? I call the plastic surgeon on call, and he's a great guy, okay? And so we're sitting there talking, and he really doesn't know what's going on, but he's at a soccer game, and there's a mom right next to him and says, oh, you go to Michael's, you get the kit, the little thing, that the grade schoolers do. Now, that's funny, but what's amazing is the next scene. The plastic surgeon leaves the game, stops at Michael's, buys 2 kits, and meets me on the 7th floor. Now, he's smart because he knew we'd screw up the first one. Okay? But here's the next scene. So here's me and this plastic surgeon mixing up the stuff with the descriptions and everything. It changed everything. It changed how they work on that floor. Because, and she had a plaster mold. And over the next 3 days, now that was just my in and out that day. And with just a little bit of help from above. And with just something that I learned at a conference like this, we made a difference on the floor for that patient. And it ended up being a good death. I wasn't part of it, but that minute or two of going in. And there's just a whole bunch of these things. With each one of these questions, you could come up with an example. It's really important to have, to understand social support that's needed at the end of life, and making sure that we get the burden of others. Most people are worried about this issue of burden, but if they have others around, many people, they're not that worried about, helping. Most people love to help. Most people do. And if there's not, there's people that are in this room that can help. And again, just some dignity of preserving practices, living in the moment. What's happening right this very minute? What can we do right now? And that's where we're going to live. We're not going to live, a day from now or an hour from now. We're living right now. And how can we do that? Every minute till the end. So what do we do at end of life? Well, the first thing is to connect with the patient, to connect with the people, to connect with your neighbor, to connect with the people you're seeing when you're volunteering at hospice, and relieve suffering. Most important thing you can do is ask how they're doing, and if they're not doing well, to raise the alarm and to get it to happen. It's a crisis. When I talk to the house staff and residents about this, I tell them, this is it. You don't get a second chance. Think about, if many of you have had an end-of-life experience in your family, it's indelible. I can remember the minute I was there with my mom and the doctor came in and what he wore and what he said. Or, I was there with my uncle. And these are precious minutes and they're permanent. And so if we're caregivers in those minutes, we have to be at our best. We don't get a second chance at end of life. And so it's really important to do that. We need to screen for depression and treat it. It's easy. It's simple. We need to use all of those dignity-conserving practices. We need to establish very short-term goals and live in the moment and explore all the options for end-of-life care. And we need to involve a community. If there is no community, make one or get one. And we'll talk a little bit about that. We need to assess the burden and benefit of what we're doing. If someone's dying, you do not need to stand in the way. Everybody's born, everybody lives, everybody dies. And it's a natural part of that. And if you recognize that this is the dying process, you don't have to prolong it. You can let it happen naturally and with dignity, true dignity. And that's actually what we're doing. We're walking with them on this very important last part of the journey. And this is what death with dignity is. If you want to ask what death with dignity, it's working with someone, it's suffering with someone, it's walking with someone to the very end. Now, what can we do? So there's an organization called Physicians for Compassionate Care, and there are some successful strategies for encountering end-of-life issues. And I think some of these have already been touched on, and we're going to go through them. Know who the adversary is, improving end of life, telling the truth about organ, getting physicians involved, using arguments, and taking back the language. The adversary, Compassion Choices, formerly known as the Hemlock Society. They have an annual budget of over $7.5 million, and their workers have 401ks, okay? Just like we heard earlier. They've got committed professional people. And they facilitate and attend most of the cases. In 2009, 97% of the cases of assisted suicide were attended by Compassion Choices. They're facilitating. They're facilitating the death with dignity. They control all the information. They actually threaten DHS. So you used to get the annual physician-assisted suicide report. The people from Compassion Choices walked over to the Oregon Health Division with a lawyer and said, we're going to sue. You can no longer call this physician-assisted suicide. It's death with dignity. And if you don't change it, we're going to sue you. We're going to litigate you for the next decade. And the Oregon Health Division says, well, we don't have a budget for that. And so since then, every year we get the annual death with dignity statistics. And everything from the state of Oregon is published says death with dignity. It no longer says physician-assisted suicide. They're very effective at controlling the tempo here. And this is an advertisement from the National Death with Dignity Center. And they won in Washington. And now they have a team that they could get together. They have the lawyer, the family member, They have the physician and the social worker. They have the lobbyist. They have the advocate. And they can bring assisted suicide to your state for $5 million. This is what they've got. They're organized. They are organized. And you need to know who they are because this is who we're fighting. This is what we're up against. And so we have to understand that this is what we're dealing with. So we need to have the same kind of commitment. We need to improve end-of-life care. We talked a little bit about recognition of suffering at the end of life, engaging the community. trying to get these, improving end-of-life care with the physicians and doing these dignity-conserving strategies. We'll talk about that at the end. But if you want to, you can go to our website, pccf.org, and these are listed. And also, if you want to, I could send this to you in email form as well. But they're just some simple things that you could have. Everyone at end of life should go through these 23 questions. If they're suicidal, there's 23 reasons why. Let's make sure it's not that. We can deal with that. And besides, it's just good medical care. And it's not rocket science. It is just, being a human being. And then, of course, this protocol, very, very, very easy to do. Doesn't take anybody trained. It just takes someone who can listen and can ask a question. The other thing, which is great, is Martha and Mary. How many heard of Martha and Mary here? So everybody, I'm preaching to the choir here, but for those of you who aren't in the choir, let me allow you to join the choir. So there's a lot of people who don't have anyone to care for them at end of life. And the existing facilities, they lack expertise, and they're unable to provide this comprehensive care. And so Martha and Mary Home was designed to be a licensed adult foster care home, round-the-clock care for up to 5 residents. And it's funded through Medicaid and private pay, and it's basically like the home for unwed moms. If you think about the home for unwed mothers as the option to abortion, think about this kind of a home which is dedicated to the safe and grace-filled care of those loved ones at end of life. And the people who are involved with this are doing this in direct opposition to the culture of death and assisted suicide. And every place, every county needs to have a couple of these. And there's one in Northwest Portland, or Southeast Portland. And that's me sort of running around at the Open Up, and we open it up. It's a great place, great people. For those of you, if there's one thing you could do, would be we're talking about how to get involved. This is a great way to get involved. You can get involved today to go and volunteer at Martha and Mary. And again, they are on the website as well. Telling the truth about Oregon. A lot of people paint a rosy picture of what's happening in Oregon. There are 5 people who might have an issue with that. Kate Cheney was a lady with dementia who was given assisted suicide despite the doctors knowing she's incapable. Patients with depression, the case of Michael Freeland, an actively depressed patient who was hospitalized for his depression, given assisted suicide. Doctors giving lethal injections, the case of Claire Today down in Corvallis, where it gave a lethal injection, it was called assisted suicide. Nurses getting involved, the case of Wendy Melcher, where the nurses did this without any physician's involvement, and also the case of Dave Pruitt, who actually took the stuff, woke up and said, "What the heck happened to me?" When it didn't work. And so when you hear about all the great things and how well it's working, it's documented that it's not working, and it's a bit of a mess, as you would probably understand. Engaging physicians. The AMA has it right. The American Medical Association says that physician-assisted suicide is fundamentally incompatible with the role of the physician. This is what we think about when we think about physicians. It doesn't really show, but this is a painting that was done in the late 1800s. The physician, it's as the fever breaks. Here's the physician at the bedside. But a couple of other things to notice about this painting is, here's the mom in the corner, okay? She's spent. She's done. She's been there. She has nothing left. And there's a dad kind of with his hand on her shoulder, not really knowing what to do, lost. The physician's the one who's there, caring, making sure that that's what we do. That's what people think about when they think about physicians. That's what they want. That's why a lot of us went into medicine. And what we have, and there's a booth outside, is we're trying to get some of that back, is we really want to identify those physicians for you. Will they take a simple pledge? This is a simple pledge. Used to be that the physician took the Hippocratic Oath. They don't take it anymore. They could take this pledge today. I promise that I'm not going to do any harm. I'm going to treat patients to my best ability. I'm not going to prolong suffering, but I'm not going to promote assisted suicide. And I do this always affirming and regarding these principles because every life is inherently valuable. It's a simple pledge. And what we have is we have a program where we have doctors take the pledge, or you as a patient can get a nice a pledge frame, take it to the physician and say, "Hey, where do you stand on the issue? Is this something you'd agree with? If not, great, it's good for me to know." one more fact, and I'll just keep that in mind when we come to end-of-life decisions. I need to know where you stand. If they do agree with the pledge, you have them hang it up. You want them to know. I have these hanging in my office. It's a great conversation starter to talk about, I'm going to take care of you. I'm not going to let you suffer an ounce to the best of my ability, but I'll never harm you intentionally. And this is something that you can do. And you cannot trust the brand. So here is, the medical director of the Catholic Cancer Program, who gave my patient assisted suicide at the blessing of the cancer program. So you just can't, you need to know who the doctor is. You cannot trust a brand or trust a slogan. You need to know where things are. We need a bigger tent. This is a pretty big tent in here. We actually outgrew the Wilson, Holiday Inn, which is kind of nice. We're in a bigger tent today. But it turns out that arguments that are faith-based have limited appeal. If we look at the, faith-based arguments, the fifth commandment, the sanctity of life, if we're looking at the percentage of, regular churchgoers by state, here we are in Oregon, we're about 30%. So if we even got every churchgoer to get on board, we got a third of the population, right? We need a bigger tent. We need bigger arguments. And the one thing that I would say is that with assisted suicide, there are other arguments that you can use. The first argument is that it's a recipe for elder abuse. Everyone can understand that. That doesn't take a lot of cognitive ability. The Adult Protective Services, they see, when someone is being viewed as a burden, that's a warning sign for abuse. And this is happening here. Also, choice is a lie. Turns out in Oregon, you can't opt out. There's no one here in the state. If you live here in the state, you can't say, well, regardless of what happens, I want to not have assisted suicide apply to me. By law, you cannot opt out of the law. So there's really no choice. Also, Barb Wagner, gal who lived in the middle of the state. She had lung cancer. She wanted to get a chemotherapy, but it was denied by the Oregon Health Plan. And in that denial letter, they say, we're denying you this chemotherapy, which had like a 50% chance of helping her. But they said, but you can have assisted suicide. It's a direct letter from the state telling her you can't have this, but you can, assisted suicide is covered, and that's one of your options. So when you're vulnerable and alone, what kind of a choice is that if you're being told by the state that you're no longer worthy of being alive? So choice is a lie, and it's a recipe for elder abuse. We need to use the words physician-assisted suicide. We don't want to use their language. Don't use death and dying. It's very precise because there are two things that happen. It's a situational killing and it's a suicide. Situational killing is always wrong and suicide is always a tragedy. Just remember those things, and what we want to do is when we're talking, there are two kinds of events. There are events where it's more of a secular event, and there are events where it's more faith-based. If you have a faith-based organization, you can talk about all of the spectrum issues in life. Stem cells, abortion, physician-assisted suicide and euthanasia. When you're speaking to secular organizations, you don't have to go there. You can make a lot of headway with recipe for elder abuse. Choice is a lie. And we have people with us who are in the pro-choice movement, and they're with us against assisted suicide. But they don't like to come to meetings like this because they feel really bad. As a matter of fact, probably the one person who's she's probably responsible almost single-handedly for stopping assisted suicide in Vermont and New Hampshire. And she's a pro-choice lawyer. She single-handedly has defeated assisted suicide. And without her, she's the one who came up with the two arguments, recipe for elder abuse and choice is a lie. And we have to be big enough in our ability to work with them and to be single issue on this when we do events on assisted suicide, and to not alienate some of the other folks. Because we actually, at Physician for Compassionate Care, we had an abortionist who was on our side against assisted suicide at the beginning because they didn't believe it was right to kill old people. And we were not going to turn down his help. He was effective in helping us with this. And we can't judge. We just need to work. And I'm telling you that one of the biggest problems with what happened in Washington were people who couldn't get along. And we didn't have a big enough tent. And that was why we now have assisted suicide in Washington. And we need to learn from that and open our minds just a little bit and work at this And I know that it goes a little against the grain here at a conference like this, but this is really critical. We need to take back the language, have a big tent. So this is what we do. This is where your marching orders are, along with Abby. I think that it's time for everyone here to get engaged if you can. Know who our adversary is. Improve end-of-life care to the best of your ability. Use arguments that work, engage physicians, and take back the language. Now, there's a couple things that we're going to talk about a little bit, and I just want to go over the advanced directive. We're going to end with this. But advanced directive is a way, some people say, I don't want one of those. It's a way for you to direct your care at the end of life. And there's, it's mostly about tube feeding and those types of things. And there's an Oregon form and a Washington form, and they basically have a number of parts here. We're not really going to go through them, but what I want to say is the most important thing you can do is to have a healthcare representative or the durable power of attorney. The healthcare representative is Part B here, and if we go through the Washington, it's the durable power of attorney. And you need to have someone who knows and respects your moral convictions. And there's a whole section on this later this afternoon, and I'm going to gloss over that. I do want to talk about the post order, physician order for life-sustaining treatment. This is an order that if you don't want to be hooked up to a machine, you don't need to be. You can fill out a post form, which basically says there's 4 parts to it, A, B, C, and D. On the top is, do you want to have CPR? Do you want to be resuscitated? If your heart stops, if you should stop breathing, do you want them to do the chest compressions and the electrical shocks to bring you back? Do you want that? Yes or no? And you can make a choice about that. The second section is, okay, you're almost on death's door. You're heading down the corridor, but you're still with us. What do you want done? Do you want everything done? Do you want limited things done, or do you just want to be made comfortable? And that's also important. And in Washington, it's a bright green form. In Oregon, it's a pink form. And I think that this part right here is the most important part. I'm going to leave you with this last story. That I had a patient, he's a 90-year-old guy, crusty old guy, World War II vet. He was in Patton's Third Army as they raced across, Germany, all right? And he was living in assisted living, pretty, dependent, needed a little help. He came into the hospital. He had a urinary tract infection. Was really sick. Actually, was so sick, he couldn't even know what he was. He was delirious. He wasn't even my patient. He was a patient of someone else's. And they called me up, and the ER doctor says, oh, he's here. He's in the hospital. He's really delirious. His blood pressure's low. It looks like he's really, septic. He's probably got a bloodstream infection. He looks like he's not going to make it. And he checked comfort care on this. And so we're thinking about just admitting him up to the floor, and, we'll just keep him comfortable. And I didn't know him, and I said, well, listen, you can't take these things, for granted. You can't take them at face value. I want you to find out from next of kin what he really wants. Says, well, his son lives in Arizona. We can't get a hold of him. Well, there's somebody at the assisted living who's I want you to contact him. Call me back. Don't just put this guy up on the floor just to, put him out to pasture. I want to know if that's what they want, then that's fine. Well, it turns out that his nephew lives, not too far, and says, oh, no, he likes what he's doing. We need to take care of him. So we put him in the hospital, 3 days of antibiotics, and he's back to being crusty old vet. And the minute I walked in, he started telling these stories, about Patton and this and that, and I was thoroughly entertained. And but that's what he wanted. But the problem was he marked the wrong box, okay? And had it not been for me saying, let's just wait a second and clarify, he would have been dead, because it would have been comfort care. So I only want to leave you with, these are great forms. I like them. They have helped me take care of my patients. And if you don't want something done, or you do want something done, it's really a way for you to get your own views followed. But the tendency with these is to do less. If you want more, you got to make sure you mark this box correctly. And that's all I'm going to say. I'm going to finish up. I'm going to leave about 2 seconds for questions. And that's where we'll go. I really appreciate your attention. We're about ready to have a good meal here. So thank you very much.